Buenos días.
Good morning, good afternoon, good evening, depending on where you are right now. My name is Andrés de Francisco. I'm director of the Department of Family
De vida de la Organización Panamericana de
Health Promotion and Life Course of the Pan American Health Organization here in Washington, D.C. I wanted to welcome you all to this webinar launching the PAHO recommendations for implementing a national system for the surveillance of maternal near miss. It's a great pleasure for me to participate in the launching of these recommendations to implement a national surveillance system of maternal near miss in the countries. I wish to welcome all participants who are accompanying us, colleagues from the Ministries of Health, our colleagues in the country offices, the PAHO offices, as well as the other professionals and people who are joining us this morning. I also wish to thank the coordination of this meeting to the Director of the Latin American Perinatology System, CLAP, Dr. Susan Cerrulla, and all the colleagues at the center who have participated in this long process, as well as those professionals who will share their successful experiences that would be useful for those countries that have not yet advanced in the implementation of surveillance of maternal near miss at the national level. The objective of this meeting is to launch the before-mentioned paper, which we would think could be a guideline so that the countries that have not yet implemented surveillance process for maternal near miss may do it, considering the different possibilities and choosing the one that adapts best to local situations. Although we still have problems to identify and classify all maternal deaths, we see that with the exception of this year of pandemic, maternal deaths were continuously decreasing in the region. But we also know that women who survive a maternal near miss have similar behavior to those who die. That is why it is important to advance in the study of maternal near miss to understand what was done right and what contributed to saving a life that of a person who would have died otherwise. And also because maternal near miss cases occur at health services, all of them, unlike maternal deaths, which have a community component. In spite of those advantages, most of our states do not survey nor study their maternal near miss cases, and that is what we wish to change with this seminar. We understand that this is a feasible way to improve the health of pregnant women, and that is why we have developed these recommendations to encourage countries to survey and review maternal near miss. We wish to remind you that these recommendations arose as a mandate from one of our member states in September 2018, and we are following that up. After hard work by an international experts group and with technical contributions from many countries in the region, we have reached this document that we are launching today, and we hope it will be used by those countries that want to go on advancing, promoting the well-being of women. With these words, I welcome you all to this very important seminar. We hope to have much participation and discussion that we may all learn, and I wish you all a very good day. And now I pass the floor to Dr. Susan Cerrulla, Director of CLAP. Thank you. Good morning to you all. Thank you, Andres. Today is a historical day in our region. We have faced a year that has been difficult for all of us, and unfortunately, very difficult for some pregnant women who, due to COVID and with COVID, have lost their lives. Some countries have shown quickly that more than that, when mortality did not occur, there were still differences in near-miss cases, as we shall see. So what we are doing today in this complex year, and that is why we insisted on doing it even at the end of the year, is to give each country an opportunity, the tools to work in the implementation of a system for the surveillance of extreme maternal morbidity. We want to survey women's health. I have a mantra for many years, which is if we advance with care of women's health, if we advance in surveillance, future surveillance of health will be that of near miss, because we will have very few cases of maternal deaths. I hope it is so. And so I wish to start by thanking each one of you. We have almost 100 participants, although it is December 16th and you are here with us, and you will take this opportunity to discuss with us, listen to what we have been doing, because as Claudio and Bremen are going to show you, we are building this story together, and to show you that we can change and improve surveillance and get better results. Be very welcome. Bremen, please, you've got the floor. Thank you. Thank you, Susanne. It is a pleasure to have an opportunity to talk to you, tell you that in today's meeting, we shall have, in just a few seconds, a presentation by Dr. Suzanne Serruja to give us a framework of maternal near miss. On the other hand, we shall also have two presentations by Dr. Claudio Sosa, who will be linked together, where he will be making a presentation of the specific framework on which the core group that developed these guidelines has worked, and then go into the guidelines per se. But we also have today the honor of having two colleagues from the National Institute of Public Health in Colombia telling us their experience, which we think is an experience that may be repeated in other countries as an example of success. They are Doctors Natalie Rosso and Grace Avila. And we shall also have the opportunity to share the experience of a Caribbean country that has advanced a lot in recent years, and particularly regarding maternal near miss, it has made enormous advances, and that is Trinidad and Tobago. And we shall hear Dr. Adesir Singh, who is director of the Department of Women's Health at the Ministry in Trinidad and Tobago. Finally, we shall have a few seconds to discuss next steps, and we would like to know if we are on time. So far, we are on time. And we shall have the opportunity to talk with you about implementation of maternal near miss surveillance in those countries that can do it. So I will now pass the floor to my colleague and director of CLAB, Dr. Susan Saruya, so that she may tell us about the fundamentals in the implementation of maternal near miss. Thank you, Bremen. It's okay. I had already said how important near miss is for us and the commitment that we all have with women's health. Well, the first thing I want to tell you is almost a historical account. We are getting older and we see that things are 10, 12 years old. But where does this come from? I believe that all who are listening to this know it already, but as maternal mortality decreased, we had an important number of women that we were saving. And they were almost dead and they were saved. And we always tell the story of where the term near miss or extreme maternal morbidity appeared. The fact is that by 2008, we reached a consensus that took almost 10 years to know what do we mean by this and why is it important to study it. We know the first one. It has the same determinants as maternal mortality. With this change, we saved the woman. We didn't lose her. But there are two serious things. We see that there are maternal deaths, but the frequency of maternal near miss may be, in some countries, 5 to 10 times larger. For every death, I have 10 cases of near miss. So if you make your numbers for your own countries and hospitals, you will see how important that is. That is why when from CLAP, we made an action plan to accelerate the reduction of maternal mortality, we included maternal near miss in it, because it is clear that if we do not work on both fronts, we will not be able to reach a development of what we want. And we had this goal for 2015. As we all know, we didn't reach it. But it has in a promissory way, countries started listening to the concept, they started discussing it and including it in their systems so that we may advance in the maternal near miss. Why do we insist that we need a regional surveillance? And we devoted our work to this. You will see that Claudio Breve will present it. I will not make a spoiler of the presentation, so just of my own. In the cases of extreme maternal morbidity, we have the opportunity to have better information. When you reach a hospital to review a maternal death, the team doesn't want to see this auditor, this colleague who will ask you, how did this woman die? But when we ask, how did you save her? We have many people wanted to answer. There is an opportunity to have more data. We have the women themselves who can report. They can say, no, what happened is that I didn't have a way to reach the hospital, or I didn't go to a hospital, I didn't receive attention quickly enough, and I wasn't derived to another service quickly enough. What we want is to identify cost-effective strategies to improve care. When we study near miss cases, we know where to improve. That is well known also. That is the spectrum of maternal health. We have here, fortunately, most non-complicated pregnancies here, the ones that are complicated with things that are not so important, some more serious ones. And finally, maternal near miss and what we do not want to reach, which are maternal deaths. We can see this in this fashion. All women who have a pregnancy may undergo it without complications or to have, for instance, a mild preeclampsia. From that, women may evolve without eclampsia or with it. That eclampsia would be enough to say it's a near miss. In the WHO strict concept, no, but when she is comatose. But we shall see that at the time of eclampsia, even if she's not comatose, we may have laboratory values of near miss and reach the criteria. And I will show you what are these criteria. They are clinical, they are laboratory markers, and they are interventions. So if I have a patient who goes for dialysis for any reason, she is a near miss case. If I have a patient who received blood transfusion with an important amount of blood, Claudia will also talk about that because there's an issue there, that is also a near miss. So we have advanced to show this concept, the criteria, and this system to all countries. And what did we find from 2010 to 2015? That we have more countries working in measuring it, but we still have many countries that had not set up their measuring system. So it was clear that we had to adopt a standard, that we have to find a common registry that was systematic to estimate the magnitude and to develop indicator, and that is what CLAP has done. There is lots of work, and you will see it step by step of the construction of the new clinical record. What is on one side, and I'm showing morbidity here, and the variables that repeat the criteria that I just showed you. That allows a system with automatic outputs and artificial intelligence to be able to help services to get data that is more realistic. And I will show you the next steps that Bremen and Claudia are going to show you are in the same direction. Near miss surveillance. Let's hope it is the future surveillance of maternal mortality. And that will mean that we shall have very few deaths, that they will be so rare, so difficult that in order to better understand how to go on implementing cost-effective implementations, we shall have to use the cases of those women we saved and not the ones who died, so that we may gather everything. The idea is to have a policy of data gathering, of analysis of those data, of using recommendations. And I always say, first locally, for those who data, who does it matter? For the person near the woman, to make reports so that the whole region may learn and to change practices and policies, trying to reach care of excellence. Here, to finish, I'm showing you a paper we published with some colleagues of WHO and CLAP and SemiCamp regarding what was happening in the different grades or degrees. And for that, we used the CLAP bank. And what did we find there? We found that in over 700 births, she apologizes because it is in English. Here we have an important percentage of women who had no problem, 62%, those with small problems, some threatening conditions. And here we have 3% of women with near miss and 0.14 maternal deaths. We have 20 times more near miss than maternal deaths. I hope
Hopefully that won't be what happens in Latin America, and hopefully we'll have lower figures. But this is the reason why from CAP, obeying a mandate of the council, we are working to ensure having teams in every country that may understand the cases of the women that have near miss. So thank you, Bremen. Thank you, Susanne. Thank you for giving us the background. But I want to highlight something that you said at the end. This is not whimsical. This is CLAP and PAHO are not just doing it because we thought of it, but This is the mandate of the member countries, and Claudio will discuss this. So this precisely is a good introduction for what Dr. Claudio Sosa says, working for CLAPE and PAHO. So you have the floor, Claudio. Can you hear me? Hello, everyone. Thank you, Bremen. Andres and Susanna, it's a pleasure to be sharing this day with you. And as Bremen said, I have two presentations. As a matter of fact, I merged them, but you'll see a transition. It's going to be a bit lengthy, but we're going to try to keep our times. We're going to speak of the background and the methodology that to develop the document, and a bit of an outline of the components of the document and the assistance that we got from other countries that I think was good quality. As to the process, as Susanna pointed out, in 2011, PAHO, the Executive Council of PAHO, approved a resolution that was for a plan of action to accelerate the reduction of maternal mortality and severe maternal morbidity. So the latter was also included, and trying to strengthen surveillance. As a matter of fact, the document, as Susan showed, had the guidelines, and the other one that was the monitoring and evaluation strategy for this plan that evolved for 5 years collecting data, and specifically in strategic area 4, there were 2 indicators. One of them was whether there was a country operating in the country to maintaining a registry of severe maternal morbidity, and then from 2010 to 2015 to see the elements for per 100,000 of severe maternal morbidity. The interesting thing that after 5 years, and we recruited the information from 2010 to 2015, 11 countries reported it, not for every year. In yellow, you see the severe maternal morbidity, and then and the maternal mortality. There was a 20%, and there was a there were countries that had from it ranged from 2 to 20%. Not only was there a variation between the countries, but within the same countries, and that happens when you start increasing the quality of your data. But there was a huge variability. So in 2018, we produced a paper, and we discussed the heterogeneity of the data for severe maternal morbidity. So that is why Mexico tried to develop a regional standard to monitor the extremely severe maternal morbidity, and then we started focusing on extremely severe. And that is how we CLAP developed. CLAP was requested to coordinate with PAHO departments and with the country officers to conduct a survey of the data to be used as an input, because there were countries that were already working. So the learning and the lessons learned were very important, but also to call a group of experts to work on the topic. The first thing that we did, and it's tedious, so we won't show you all the data, but for some time with 29 countries, we requested the countries to describe their national or the center data. We thought that the centers were important because you'll see that the near miss happens at the centers, at the facilities. So using some facilities for measurement is feasible, and we were interested in doing that. And we asked them to describe the criteria that they used so as to use the best evidence definitions in the region. And we also asked the countries to see what forms they use to collect the data. As a matter of fact, what I'm showing here are 6 of the forms that we received from the various countries. Some were using the perinatal information system before the plus. Others had their own documents, and others, like Uruguay, recorded the near miss associated to special admissions. So there were different forms, but this is what we surveyed initially. The other important thing that we were requested was to form a core group. So with the promise of calling experts with the academic experience on near miss and on the surveillance of near miss, we needed the expertise of many countries that were already working on this topic in the countries. So we created this group with the regional and international experts because WHO also collaborated. WHO staff got gave the definition for near miss in 2018, and they also supported us actively. So with the input of the regional survey and with telephone conferences, and finally with an in-person meeting in Panama in July 2019, at the time we assessed the situation up to 2019, the situation of near miss in the region, and for an entire day we defined a regional proposal so that everybody would use a common denominator, at least to report it internationally. Here you have a picture of the group, that part of the group, because at the end there were people who had to leave earlier because of their flights. So after evaluating, the core group reached a conclusion that it was important to use one single definition. And since the definition is much stricter because some variables are more severe, the idea was to use the definition of WHO so that we could compare it not just in the region, but to compare ourselves versus a benchmark with other continents to avoid, to get a good comparability. So, and obviously the countries that had been working successfully, they could continue to work with the format, with the definition, but as we're going to see that they are broader definitions, we requested them to report it. So when they asked for the surveillance, we requested them to use the WHO definition. So the information was available in those countries. So here, this would be the definition and the indices, the results by implementing WHO definition. So this was reported by the countries. Now, so with this, we completed the process. We have a version in Spanish, and it's been translated into English and Portuguese, and we are completing the Portuguese version. So with this, we complete my talk, and if you have any doubts later, we can discuss it later on. And now, let's get into the content. This is the Spanish version. It has 33 pages, and I'm going to give you an outline of the contents and adding some international definitions. But we wanted it to be based on the best evidence available and with a feedback by the countries. Today we're going to have a presentation by Trinidad Tobago and Colombia, who have succeeded in the management of the near miss. So we could have invited some of the countries, but those were the 2 countries that we had already worked with in Panama. Basically, the guideline of the document and the target, especially for the countries that have already worked at that, is to recommend an international report of the criteria of maternal near miss as defined by WHO. Obviously, those that have already prepared surveillance and developed forms, etc., the networks are already working. Of course, for them, this will be just an additional input, but they will need to add the WHO report to ensure comparability against international data. Of course, this is internal input to be used for this purpose. There's a specific chapter, the definition of a maternal near-miss, and we reported the history of the various authors that used the near-miss criterion. Why is there such a variability? Because, well, in the case of maternal death, it's very simple because there was a pregnant woman or a postpartum woman, and it's very easy to define them once they die. But as Susan said, that would be the red part. There you have in black the maternal death, but there are many variables that may go unnoticed in the daily practice, and they may not be detected as near miss. But near miss implies a complex um, definition with 3 dimensions. And basically, as Suzanne already mentioned, it's based on a clinical criteria associated with specific disease and criteria based on a systemic organic dysfunction and criteria based on a specific intervention. You already know this chart. It has systems to your left or organs or systems, cardiovascular, respiratory, renal, hematologic, liver, neurologic, and uterine dysfunction. And in a matrix, this could be divided into clinical criteria so that the clinicians can establish the diagnosis without any lab tests. And we have 13 components. Then you have the lab markers that require a lab, not a very specific testing, but some centers may not identify patients because they lack these tests. And then intervention-based criteria. Now, let's discuss each of them to show you how complex it is to apply a definition. Mantel's criterion may be the simplest for a clinician because based on a condition, as Susan pointed out, I have a preeclampsia, that's a near miss. No, it's a preeclampsia with certain characteristics that add something specific to, for instance, renal failure, jaundice, or any other element that you see in this chart. It's simple to apply and it's cost specific, but this would leave out many severely ill patients that from a clinical point of view would not fit. Then we have the lab markers such as severe hypoperfusion, severe acidosis, severe acute azotemia because of renal failure, acute thrombocytopenia, acute hyperbilirubinemia. And so these are based on the concept of a sequence. And so here, before we have any clinical elements, we may diagnose. There's an injury, and here I'm showing it in the pyramid. There's the injury causes a systemic inflammatory response, and at some time, after a certain cut, and the cut is important because there may be differences in some of the variables, that gives us organ failure, and then we would have another cut before we diagnose near miss. It's a specific cut, but we need to have lab tests when we face this situation. And it could not apply to all the levels of care. That is why we often concentrate this as first and second level where there are more critically ill patients. And the third group that is also simple is the intervention-based criteria, such as medication, vasoactive drugs, cardiopulmonary resuscitation, or intubation not due to anesthesia, dialysis because of acute renal failure, or massive transfusions, or hemorrhage or infection leading to hysterectomy. So sometimes these interventions depend on the logistics. Hysterectomy, in some cases, facilities may be more easily done than in others. So sometimes it also depends on the number of beds and resources, so that would be a constraint. But anyway, you have clear signs that this is a high risk group. There are 25 variables that are distributed in the various systems. 13, 6, and 6, the clinical criteria, lab markers, and interventions. And basically, the concept is if I have a near miss, for instance, when I have one of them, for instance, cardiopulmonary cardiac arrest or dialysis with because of acute renal failure or jaundice in presence of preeclampsia, that would be a near miss, or prolonged unconsciousness or coma, that's a near miss, or hysterectomy because of infection or hemorrhage. So there we have the near miss that has been defined, and it's complex because sometimes in the management of severe ill patients, so of course what you worry about is to save the patient, and you're not thinking of recording, but it's important to record it, and it's sometimes the cause of the heterogeneity of the information. It's important to remember that the near miss, because of its severity, occurs almost with no exceptions at the facilities. A patient as severe as this in the community, if she is not referred, it's very difficult for her not to not to die. So this makes sense. If I think of acting here, I will start acting in facilities with the more complex in the facilities, with where there is a blood bank or dialysis center or operation room or intensive care. So we can identify the facilities. Of course, when we speak of the national care, we want indicators representing the entire country or the entire region. However, we know that there's no doubt that the more complex centers or facilities are the ones that will succeed better. And so at these facilities, the near miss will not end up in a maternal death. There are two possibilities, basically, as we always say in epidemiology, prospectively. Well, the epidemiologic surveillance with cohort studies. I can identify a case that appears and I'm monitoring that. That would be the best option. But very often, due to logistics constraints or human resources, we cannot have it that prospective way. So we can do it retrospectively. So the user or the patient, we can identify the population group that could have had the problem, and we identify the population. So in surveillance, we have two possibilities. The perspective is we identify this actively when it happens. Imagine that you receive a patient who needs a transfusion. She needs 5-6 volumes of blood. Sorry, he has a bad connection. So the case is identified and recorded and notified. And if she ends up in death, of course, she will no longer be a near miss. So this enables us to monitor, to do the follow-up of the patient and to check that she's discharged and she doesn't die, especially because now the severely ill are sometimes at the intensive care unit for a long time. So you need to complete this and put the outcome when she is discharged. And then you may need, and if you do it retrospectively, you may have to screen the groups to check that there are near misses. But as the document says, the ideal thing is to do a prospective surveillance.
In the scenario number 1, talking about prospective surveillance, there isn't much to be said. The institutions that we'll be talking about use it. You choose a model of data collection prospectively based on a clinical record that already contains those variables or through a specific form designed for that, which is the case of Trinidad and Tobago, which uses the perinatal information system, or Colombia, with a reporting form that is very complete and is filled as events occur. Clearly, if we had to show them, here are the forms. We have a series of patients. I identify a patient with postpartum hemorrhage requiring hysterectomy. Medical treatment wasn't enough to revert. She went to the OR. Hysterectomy was performed, and this is a maternal near miss. If she doesn't die in the next days, of course, and so it will be recorded in real time and passed on to the database. The same with preeclampsia and jaundice. This somehow allows a fluid input of data and continuous monitoring. The second situation for countries or institutions sometimes that do not have the possibility of gathering data with the clinicians to use an external team similar to what we do with maternal death. A team knows there is a severely sick patient. The team goes, checks the medical record, looking for variables that define near miss. But when we do it retrospectively, long time after the event, it's not easy to review all medical records, to look all the laboratory results, to wonder whether everything was written, because clinicians often do not record everything. And sometimes we need other sources of data like laboratory, surgery, ICUs, etc. In order to decrease this amount of work and possibilities to go to records, try and find a group, a patient at risk. WHO proposes people with severe complications, bleeding, eclampsia, severe preeclampsia, critical interventions, interventionist radiology, received blood or hemoderivates, and that decreases the group of medical records to review, which are then analyzed looking for maternal near misses. Screenings are to make it more sensitive of everything: medical record, list of blood banks of transfusional medicine, laboratory tests. Sometimes the laboratory identifies it and says, I have this value. Is it an outlier, an error, or is it a severe patient? That's relating it to the patient in order to identify a near miss. Admissions to special care units, screening by epicrisis through the databases with CIE-10. And another possibility that we had considered as a third scenario, and then we decided to take it out because we reviewed all published evidence regarding screening of near miss. We found some CDC papers where they said that when you're faced with the impossibility of exhaustive screening of the whole record, they propose, and there are papers about this, to take some parameters. They consider two that are sensitive and specific, such as blood transfusion of 4 or more blood volumes, and or admission to intensive care with a predicted positive value of maternal near miss of 85%. There is limited evidence, of course, for this. And we said that it might exclude some maternal near miss cases that are not associated to hemorrhage or go into the ICU. So it's not a recommendation to propose, but it is thought. If you're faced with doing nothing and still you want to work on this issue, and you do not have enough human resources or you have logistics problems, you can use it, but it may affect comparability. You may have less cases of near miss than actually exist. Two issues that we discussed a lot with some countries in the region, using WHO definitions, for instance, that has this cutoff point with blood volumes. There are two variables in which we found most differences. in countries is that WHO defines 5 volumes of hemoderivatives or blood, and FLASOC have proposed 3 volumes. We may go on recording 3 volumes because that is what countries use, and that will allow a comparison with their own figures. But what we ask, if from 3 upwards you are going towards the WHO definition, I ask you to report when we require the WHO definition 5 volumes. Some databases take that as a continuous variable so that the country or the institution need only decide which cutoff point to use, and it will report the indicator as it pleases. The same for laboratory and severe hypoperfusion. WHO proposes more than 5 millimoles lactate as severe hypoperfusion. That is very severe, but some countries have a lower cutoff point, more than 4. Well, this is a variable that those countries that are working on it will not be harmed because they do not have to look for patients who are not severe enough. They just have included them, and they will have to report so that we can compare that. And this is one of the graphs of the scenarios that is in the guidelines. We have already included it, and you may check it. And after you have identified the case, what the guideline proposes is to identify it and then follow the road that we have learned about maternal death. Maternal death committees, particularly. We have worked a lot in surveillance and response to maternal death, including perinatal mortality as unified committees, and it would be easy to add this in institutions with few deaths. Suzanne was saying that the relationship is 5 or 10 to 1. If I have 2 deaths every year, perhaps I shall have to review 5 to 10 reviews for death, perhaps even less if we use the WHO criteria. And this would allow committees to work continuously and to be always ready to perform audits. So the work is the same. You have to retrieve information about the cause of maternal diabetes, see if there were delays of any sort, and as Suzanne said, to stress the actions that led to success, because it was success, and what prevention methods we have, and what we have to do to avoid future cases. And always with the objective of not using audits to blame anybody. This is for learning and providing positive feedback to improve results. This paper does not mean to be a work for full implementation. We had some guidelines. Some countries already have more extensive and complete implementation documents, but the action plan for implementation is similar to that of death. Audit and feedback using list of evidence-based interventions, if they have been incorporated, activities in training and reminders to improve management, development, and application of protocols and guidelines, clinical guidelines, and to incorporate opinion leaders at the local level who help a lot in epidemiological surveillance to know why we do it and its importance. And of course, at the institutional level, the development of reports that describe patterns, estimate delay, describe strengths and weaknesses of the system, try to stress evidence-based interventions, which must always be present, and particularly to incorporate its culture of patient safety and continuous improvement. This defines the process that we suggest. This is at the institutional level. You identify the case, you gather information, you analyze it and assess what we can improve. And this is a cycle within the institution, but what we want is that the institution reports at the national level so that the country may group its different regions and institutions and report at the national level. Some countries may even set up regional committees which gather data of near-miss from several institutions and analyze it grouped, and may reach the conclusion that they have a lot of hemorrhage that requires improving blood bags in a specific situation, and that is a local, regional, district response that depends on the institutional management of data shared with the region. Closing, I promise. We talk about surveillance, we talk about indicators to remind you that in order to report or for the institution to assess an indicator, it has to consider number of live births, number of maternal deaths, because we have indicators that are complex and complemented between deaths and near miss. And then, according to how they gather data, there will be variations, but we shall have the near miss event defined, as we said, according to WHO criteria. The data on births, maternal deaths, and near miss should be for the same time period and the same regional area. So we've got to consider, when we are working in a maternity ward, to consider all the epidemiological aspects of time, space, in order to define an indicator. The three indicators suggested by WHO, but the ratio of extremely severe maternal morbidity, the maternal near miss and mortality ratio, and mortality. Finally, what we want to do is improve data, decrease variability, avoid heterogeneity, and that is why the WHO definition was proposed, that this is national as far as possible, but we do not rule out that some countries work with sentinel centers. We know that REMIS concentrates in some areas or centers, and you may have a sentinel center to start working there and gather data that sometimes are representative of a large portion of the national data. And it's important for countries to see how and where they should work to use this data. And if we manage to have national reports of equity data, this has to do with age, ethnicity, geographical area, educational level, because this will allow us to know where to work to decrease the existing inequities, and also the cost or etiology. The MS may be being comatose, but it may be due to sepsis, to hemorrhage, to hypertension, and that will give us a need to work differently to decrease these complications. And this scheme would be, once they have this near miss data, to report regarding equity by age, ethnic group, geographical age and education, and etiology. And CLAP is working on a form. This is a preliminary form that will be sent to all countries, because it was requested that we work like this by the member states, of course, and it will have not just near miss, but age, ethnic group, areas, rural or urban, educational level, and the causes, whether it was hemorrhage, hypertension, infectious, thus being able to have better quality of data to improve our responses. Of course, this will be taking place during 2021. This new form will be sent to countries so that from March to May, there may be reports of whatever countries have regarding near miss, and that would allow us to start seeing less heterogeneity, and if there is heterogeneity, that it is accounted for by specific issues leading to near miss in the different countries. Basically, this was everything. We shall talk a bit later. If there are questions, we may respond them afterwards. Thank you very much, Claudio, for your presentation. It was very good, and I think that we are all exhausted with this presentation, to tell those who have written to us that those who registered for the workshop will receive the recording in order to have to be able to use it. From now on, I do not know in which order, but just share the word. Dr. Natalie Rosso and Grace Avila, who will be telling us about the Colombian experience. You have the floor, so we are inviting you to upload your presentation and to tell us about your experience. Thank you very much. Good morning to you all. Thank you very much for the invitation. My name is Grace Avila. I'm coordinator of the Non-Communicable Disease group in the National Institute of Health in Colombia. And Dr. Natalie Rosso is the person in charge of this issue at the Institute. First of all, thanking you for the invitation. For us as a country, it's very important to introduce this experience of almost 8 years in the implementation of surveillance of extreme maternal morbidity, 8 years of learning and permanent adjustments to achieve that national standard of data in the surveillance of extreme maternal morbidity, which is not simple because it's not easily defined. It's a series of clinical epidemiological factors that are gathered to define an event. So we shall start with something very important for us, which is a cornerstone for us in the surveillance of in the country. It is the public health surveillance system. Colombia is a country with 32 departments, 5 districts, and 1,117 municipalities. In this sense, the framework for public health surveillance has been regulated in the country for many years, but specifically we have 2 very important rules. Decree 3518 of 2006 and Decree 780 of 2016 with regulate public health surveillance, which is mandatory for all the 37 departments and all districts and municipalities. And that is what we think is very important to stress in the Colombian system. It's not an isolated system. We survey the whole public health system comprehensively. So we have almost 5,000 primary units generating data. That is what they are called, including public and private health institutions without exceptions. We do not divide them. All the institutions providing healthcare are there, and it's almost 5,000. That is the flow through which institution flows. Health institutions identify cases immediately, they report, and there is a routine flow of information to other levels, to the municipality, the department, and the national level. What these recent years have taught us is that we may work not just in the surveillance system, but we've got to articulate with the other actors. We have integrated insurance schemes, and of course the Ministry of Health and Social Protection, which directs and coordinates and regulates all the policies on which information is based. As I told you before, the public health surveillance is the cornerstone. It captures over 100 events of interest in public health, and that is why we have managed to have the coverage at the national level. Both public and private, it is under the same surveillance system. Regarding the system in Colombia, it's important to mention that it was established in 2012 as national surveillance done throughout the national territory. And this is thus from pilot studies carried out in some departments that had started surveillance, but due to the WHO recommendations, Bajo and CLAP, we started with a national surveillance. In 2013 and 14, we started with municipal secretaries of health. And of course, we also did some adjustments with implementation of surveillance throughout the country.
So all the facilities, regardless of the complexity, but depending on their human resources and their resources, could identify maternal morbidity and report it to the surveillance system. In 2014, And thanks to the routine work, a change was made at the time of reporting. Initially, that is in 2012, the notification of maternal morbidity was done when the mother was discharged because the severe obstetric problem had been solved, or when she was referred to another facility. However, the notification in 2014 and 2015 was changed to an immediate notification. So as soon as I identified that that woman has an extreme maternal morbidity, she must be reported to the surveillance system. So at the time of notification in 2015, we included in the public health system, we include the insurance company. So, and in the extreme morbidity process, the insurance company is in charge of monitoring the patient individually, immediately and right after discharge. In 2015 and 2016, based on the work conducted in those working tables, we started reviewing the criteria for inclusion of cases. And in 2017, we had an additional working table with CLAP, Bajo Colombia, the Ministry of Health in Colombia. We checked the criteria, including severe preeclampsia, sepsis, and organ failure. In 2017, 2019, the National Health System, under its process of improvement of the surveillance system, they implemented an early alert system that is used for other conditions, communicable and non-communicable. And extreme maternal morbidity is one of the most important ingredients there. In 2019, we participated in the group of the Americas in Panama to create the American standard for the registry of the near miss. Among the initiatives for the beginning of surveillance in Colombia in 2012, and here I'm showing you some departments who were already working previously to include not just the surveillance of extreme maternal morbidity, but the analysis to see how it could be reduced in our territories. So based on that timeline, the purpose of the surveillance of extreme maternal morbidity had some modifications in 2012 and 2014. The idea was to identify the cases and to the complications related to extreme maternal morbidity and some factors that triggered these complications. And starting in 2015, and based on the changes of including the insurance company as a key player, it evolved, and now we have the activation of immediate response mechanisms so as to be able to provide comprehensive care and to reduce the odds of a fatal outcome. So in so this is the definition of extreme maternal morbidity in Colombia that was suggested by WHO at the time, and this is still current. In addition to the operational definition, we have established the inclusion criteria. You see on the slide that they are three categories, and in the 2012 protocol, they define the clinical and lab characteristics for each criterion. So those in red, you have those in 2012, and now in blue, the 2015, you see the most recent adjustments, including some specific criteria in a category that Colombia has, that is a specific disease, including 5 potential conditions that are highly relevant in our epidemiology because of the chances it has to intervene in a timely manner these women with severe obstetric condition that require intervention to reduce mortality. And this in colors is the 2020 criteria that are related to what Clap said, and this was developed based on the suggestions at the Panama meeting. It's important to mention that these criteria have their clinical characteristics, their lab markers, their potential interventions, suggesting extreme maternal morbidity in the annex of the surveillance protocol. The surveillance protocol of extreme maternal morbidity is there since we started surveilling in 2012. And each year, based on lessons learned, we make the relevant changes because that's the way that Colombia standardizes the surveillance process, and we provide the guidelines so that all the authorities at the different levels may implement this in the surveillance of extreme maternal morbidity. In addition to this, we have a notification form that is filled in when there is an extreme maternal morbidity, and it has two aspects. The basic, we have the first one side, the demographic information, etc. And then in the back, we have all the data related to extreme maternal morbidity, including the gynecologic and obstetric history and the criteria, the clinical criteria, and then we have the management of the patient and the morbidity causes, and whether the patient is discharged home or referred to facilities with greater complexity. And then we have the causes of morbidity associated to this event. So in this slide, we see the evolution of the healthcare facilities notifying extreme maternal morbidity. You know that in 2012, that's when we started with surveillance in Colombia. They reported 259 public and private facilities reported, but as years went by, we had an increase of the centers that report, and this shows the possibility of compliance or the acknowledgement of the importance of this system, and now it is mandatory. So in 2020, 667 healthcare facilities have reported extreme maternal morbidity. In this slide, we see the behavior of extreme maternal morbidity for Colombia, considering the PAHO criteria in the blue bars, showing that from 2015 to 2016, we had an increase, and that is normal when you're implementing surveillance systems. But we see that starting in 2016, so up to 2016, there was an increase, but then the process was already established. In green, we have the maternal mortality ratio, and we see that the tendency is for it to drop. So with a lower maternal morbid mortality. So after notifying an extreme maternal morbidity case, there is a process with individual interventions. All the women with a case have an immediate monitoring, and then they are monitored after 72 hours, and then after 42 days, and then 3 months later. It's the insurance company that is in charge of checking this and to ensure that the woman receives care at the proper facility, reducing all the administration procedures, and they need to evaluate how the woman evolves. It's very important to consider that the to work together with the Department of Health, because this is a specific action of the programs of in 2018, there was a coverage of 66.5%, in 2019, 80%, and so far in 2020, 78.9%. That's a coverage. This activity is a process that is currently done and is established in the surveillance protocol of the National Health Institute, but we are working with the Ministry of Health. So based on the early alert system. This is a strategy that was implemented in 2019, and it enables us to strengthen the time in when the key stakeholders receive the notification. In this case, for the country, it's the insurance agencies and the Ministry of Health. When the Ministry of Health reports a case under the eclampsia, severe eclampsia, or severe hemorrhage that are key for us to identify. When they report this to the surveillance system, the system is programmed to send an alert. So an email is sent to the insurance company. So in real time, the insurance company knows what are their cases that have a greater mortality for them to deploy the actions that are related with the follow-up actions, both immediate and after the discharge. This is done, and despite the pandemic, we've been able to implement it this year. So this is, in a nutshell, the experience that we had in Colombia. I don't know whether you have any doubts, but I'll be very happy to answer them. Thank you, Natalie, and thank you, Grace, too. The presentation was absolutely spectacular, so we thank you. The problem is that I think that our interpreters will die between Claudio and you at the speed that you're speaking with. We hope that they survive until the end of the meeting. Well, I was joking. So let's try to answer the comments and the questions and we'll try to answer all at the end of the presentations. Now, we're going to request Dr. Adesh Singh from Trinidad Tobago to tell us about the experience of their country in the implementation of their system for the control of near miss. So Adesh.
Hello, and thank you for allowing the Ministry of Health to participate in today's webinar. So our presentation may not be as detailed and as mature as the presentation from Colombia, as Trinidad and Tobago is somewhat new to the surveillance of maternal near miss and so on. So first, again, let me again say thanks to the team at PAHO and CLAP for allowing us to share. A special thank you to Dr. Suzanne, Bremen, Claudio, and all of the other members. They were the catalysts for our team reaching to this point to be able to share this presentation. So for those of you who may not know, Trinidad and Tobago is one of those tiny dots that rest off the coast of South America. We are the southernmost country. We are a twin island state where we have just under 1.4 million persons. Most of the persons reside in the main island of Trinidad. We have a birth rate of approximately 11.5 births per thousand population and a death rate of 9.5 per thousand population. Women, as usual, live longer than the men, 76 years to 68 years. Our fertility rates have also been declining with 1.7 births per woman and probably less at this point in time. We are a fairly well-resourced country, and approximately 6.5% of our health expenditure, that's the public health expenditure, is as a percentage of our gross domestic product. In terms of just as a snapshot, what happens in obstetrics and our deliveries, there are 6 public health institutions and 13 private institutions that do maternity care. 91% of births occur in the 6 public institutions, with 9% occurring in the 13 private institutions. Private meaning self-funded institutions. And generally we have around 16,000 deliveries in Trinidad and Tobago. So it's a 2-tiered system with public and private sectors. The country is broken up into different regions based on where there are hospitals, geography, and so on. The system is free at the point of delivery. And of course, the private sector is based on a profit system. The private sector is not, doesn't have the resources for very high-risk obstetrics or neonatal services. So though we have a relationship that any case that is in the private sector that needs care in the public sector is seamlessly transferred to the regional health authorities. And additionally, there are very few deliveries that are actually not institutionalized in Trinidad and Tobago. In the past, we actually had home deliveries, births at home. We have moved away from this based on several issues that have happened across Trinidad and Tobago. And over 99.9% now occur inside of an institutional facility, which helps our data collection exercises to be more seamless. Our unit, which is the Directorate of Women's Health, we started our formation in 2017 when I was appointed. This is a new unit at the Ministry of Health, and it was in response to a number of alarming events in maternal and newborn services in Trinidad and Tobago. And in 2018, we would have started the systems of getting all of this data as my team were assembled. So we have someone named Dana to thank for these lovely charts. And this is what we do. We have a snapshot of our births, some monthly births. We need this information, of course, to be collected from all of the private and public institutions. And this information is received by the 15th of every month. This just shows you what happens. There's a bit of a seasonal trend in our births. We have a fairly low period and a high season, and it helps us to plan our services in terms of staffing and whether people could go on leave, resources, and so on. So we are up to date up to November 2020 in terms of the number of births that have happened in Trinidad and Tobago. In terms of the near miss, which we are discussing today, there are actually 3 lines of reporting. There is a pre-existing adverse events policy, which you are mandated to report up to the Ministry of Health, which existed before I came into office. We have the developing perinatal information system, which we are migrating and heading to become a national system. Right now, it's more in the public system, so we do lack some data. But we have a fast-track, very simple system to get quantitative data on these near-miss cases. So near-miss cases are identified, as you've heard before. They're submitted up to the Ministry of Health. And then in time, we get the qualitative reports, which comes to this directorate. So in this adverse events policy, we are mandated, this is all facilities must report these cases, and those are the ones that are peripartum cases. And there are, as usual, many forms, lots of data being collected. And then these are internally at the unit. They are to be, of course, analyzed by the clinical governance units, and quality improvements occur at the local level based on their internal analyses. At the Ministry of Health, however, this is a very simple form that we use. In addition, of course, we have the SIP working, but this very simple form works very well for us because it has the key indicators that are needed to populate and work out all of our statistics. And in this, this is our near-miss criteria called SAM. And all of the definitions were shared. We had stakeholder meetings. They are well aware of what is needed. We work very closely with our stakeholders. It's a very small country. We know persons by name. There are very few of us, and we had to adapt this system to work for our country. This works very well in similar countries in the Caribbean. This is something that can easily be done. And of course, we have used the standardized criteria. So this is our figures here, which show that for our near-miss events, we have them just on a chart. It's very confusing a bit to look at the chart, but there are very few events. We went up to 17 at most on any given month. This is the data up to October for our near misses, and we just actually had 4 near misses nationally recorded on this chart. And in terms of what numbers, we spoke about this earlier, and I heard it. We have the ratios that we work out. So our maternal near miss ratios for the last years and up to October 2020, this is up to October. 6.6 per thousand live births, 8.1 per thousand live births, and again around 6. We also, this is an important ratio, what's happening in terms of the number of near misses to maternal deaths. This year it was 36 to 1, 25 for 1, and this year it's 18 near misses to 1 maternal mortality. At this point in time, Trinidad and Tobago has actually experienced 4 maternal deaths up to present day. So what are some of our challenges? Of course, like everyone else, establishing new systems, being new to the Trinidad and Tobago norm of quality data collection. We have to work with our persons one-on-one, work in teams. Sometimes it can be challenges to get data from non-maternity areas, but it's of course, as I said, because so much is institutionalized in Trinidad, it's not so much of a challenge anymore. We want to sustain, of course, the perinatal information system as the standard. That's our decision. And of course, we are building on all aspects of SIP, including using it for the near-miss cases. It's about establishing a culture and keeping that culture going. We are sensitive to what is needed for regional and international reporting. Of course, always knowing that there are limited financial resources. So how did we overcome some of our challenges? Well, of course, we looked at readily available staff. And for most of us, we have a number of residents in training, and we help to empower them to take charge of data as their projects during their postgraduate training. And that has been working quite well. We establish dialogue with different units. We do spot checks, site visits. As I said before, we are doing the SIP Plus and SIP implementation. Here in one of these photos, you can see one of our doctors who was well trained in the SIP is using the SIP Plus, and this is at a very district hospital way out in the east of the island. So it can be used wherever, and of course, this can be expanded to all of the different centers. So we are working well with private centers because we need to get those 9% of patients covered in terms of their data and ensuring that they are transferred to the public centers, which are better equipped. This has also informed us in terms of policies as well. So we don't just look at data. It's so we're getting this data in a proactive manner. We're using it to inform what we need to do. And we have made a number of clinical guidelines as a result of the data we have analyzed coming from those near misses. And of course, everything, we must have some mandatory aspect to it. In terms of Colombia, we heard that there are laws to govern this as well. So this is our successes, really. We are proud to say that since 2016 in Trinidad and Tobago, we've had no maternal deaths from postpartum hemorrhage. We have continued since 2017 to meet those SDG targets, and even better, since 2017 as well, we have kept our maternal mortality ratio to close to 30 or less per 1,000 live births. And our neonatal mortality ratio is actually, for this year, it's actually a little under 7 per 1,000 live births. So we have had a tremendous reversal of what occurred in the past. And that transcends to approximately 80 to 100 babies and 8 to 10 mothers now surviving on an annual basis. How did we do it? Of course, we of course formed the directorate, but we were driven politically at the highest level by the Minister of Health and the Office of the Prime Minister in order to have this done. And there's a recognition, there's buy-in from our stakeholders. We do continuous support, data quality checks to ensure that there's accuracy of what we have. What are our next steps? And well, we are discussing that today, of course, and we are ready and willing to implement, not just talk about policy, to transcend it into implementation as soon as we're ready to go. With respect to anything that's decided, we're going to continue implementing our SIP and, of course, continue to do a better and more robust analysis of the data that we receive. I want to say thank you again. Thank you for allowing us to be here. Thank you.
Thank you, Adesh, for this presentation. We are almost reaching the end. We shall summarize. We have a few questions, but before that, I would like to share with you the next steps. Please, Adesh, could you stop sharing screen? Well, we were going to tell you about a document that will be made available to all of you. Thank you, Adesh. It is a document that studies the situation of countries in the region, identifying bottlenecks and that were affecting the implementation of a system, of a national system for the surveillance of maternal near miss. In that process, which was carried out in several countries where we were working, some of them have participated here because they have successful experiences such as Colombia and Trinidad and Tobago, but also in some countries that have not managed to implement a national system for near miss yet, such as Bolivia, Guatemala, Honduras, Paraguay, which is in the process of doing it, Peru, that is also in the process, and the Dominican Republic. But what a consultant did, sociologist Florencia Aguirre, she reviewed the existing literature, and she also conducted 24 in-depth interviews to national health authorities and technical personnel from the National Institutes of Health. Those interviews were conducted this year, and institutional bottlenecks were found, or barriers at the national level. For example, at the institutional level, she stressed the low availability of human resources or the low level of knowledge of this issue and training of personnel. That is why this is a very good step forward, and we thank the number of people who are participating today in this webinar. The lack of leadership from the institutional level regarding governance of ministries of health or institutes of public health, and the low availability in some occasions of the development of technological infrastructure. And finally, the colleagues also see at the national level the limitation of a lack of leadership and political will to advance in these processes, and a lack of a regulatory framework. You saw how in the case of Colombia, that was clearly established by regulations that are directed to public and private institutions as care providers in the Colombian health system. On the other hand, there is often a lack of definitions of methodology for these systems, and that is why it is important to have common criteria, not just to communicate regionally, and that we may work with that information to suggest actions, but so that at the country level, independently of what data they are gathering and that is different from other countries, that the country has a common criterion with which it analyzes and develops policies. And of course, something that is always commented is the lack of financial investment. Based on that, documents are available. Those of you who registered will receive through emails the recording of this meeting, but also to tell you that in the next steps, we shall need first to know which countries are willing to advance in the process of generating a national surveillance system, and that in CLAP we are open to perform technical cooperation through our country offices. That is why our colleagues, what we call focal points in FPL in the countries, are able to provide responses and coordinate actions. In many cases, our own experts are able to lead the processes without our cooperation, but sometimes they might require it. And from CLAP, we are open to work despite the pandemics in 2021 in this subject. We are near closing. We are 2 minutes behind, but I would like to include some of the questions that we have received. There is a question that I will pass on to my colleague Claudio. It's a question by Nareen Singh, and question is that in some cases, to perform a C-section in patients who have 8 degrees hemoglobin, 8 milligrams hemoglobin, I'm sorry, they do a prophylactic blood transfusion. Would that patient qualify as a near miss, Claudio? Well, we've got to see what kind of point shall we use. It's not frequent that in a pre-op we might give 5 volumes of hemoderivatives. That patient with a severe anemia is identified. She's a patient who's at risk. The near miss concept also often is a response. I had to transfuse because there was an important hemorrhage, and we transferred 5 or 3, dependent on the cutoff point. Let's use 5. But when analyzing it, it will be a near miss because if she received those volumes and would remain as so at the level of the response, it's a different situation, of course. Thank you, Claudio. Laura Gomez from Guatemala tells us that she works in Huehuetenango, and they do not have these definitions, nor do they record this, and she's requesting the forms for the definitions. And of course, we say that with pleasure, we shall be sending them, but we would like her to get in touch, particularly with Dr. Amalia Shala at the Bajo office in Guatemala, and she will be able to provide far more support than we can at a distance. But anyhow, be sure that we shall respond to your request. We have also seen a colleague from Peru, Catherine Ortega, makes a series of comments, and unfortunately, the Ministry of Public Health of Colombia or the Secretary of Public Health of Colombia is not participating because it is the one that should respond this, because our colleagues from the National Institute of Public Health in Colombia are not related to these subjects. Anyways, I would like to tell you, although I do not have full information, you tell us whether it is necessary for pregnant patients in Colombia to have access to health services 24 hours. They do have it. And you said, do you think that the midwifery profession should be implemented in Colombia? Well, the profession as professional midwife, as it exists in Peru, does not exist in Colombia, but they have just regulated the obstetric nurse profession. I know there is a struggle between these two professions, but it is the one that will be working in Colombia because of the government decision. And it would be taking this space that in other countries is covered by professional midwifery, such as the case in Peru. I do not have other questions here. Anyways, if there are no further questions, I will give the floor to Dr. Suzanne Cerrulla, the center's director, to close this meeting. And I thank you. And I thank all the lecturers for having been with us, and to all of you. And to repeat that we are available for all of you from CLAP. Happy New Year, considering how difficult this year has been. And I'm sure that and hope that we shall keep seeing and hearing one another next year. Thank you, Bremen. As I said at the beginning, thank you very much to each one of you who have been here with us in this hour and a half. I particularly wish to thank Grace and Natalie, who have shown the strengths of Colombia, and Adesh, who has shown how everything is going well in Trinidad and Tobago. I think these are two very special examples to show that it is possible, that we can do it, and it is a project for the long term, but I'm sure that each country may build it and have it, and we need it. You have seen that Claudio's data, what Bremen showed, the need we have. I wish to thank, well, at this time of closing, I also wish to thank those three lecturers. I wish to thank Bremen and Claudio, who have not only lectured, but they have been working on the paper for months, on your contributions, all those of you who have contributed to these guidelines, and particularly to this enormous group of colleagues from PAJO, the country advisors, focal points, who have contributed. Here we have the action in the hand of many of you in some of our meetings. Finally, beyond thanking Bremen, who has coordinated all the maternal health actions, I also wish to thank this team, who are the translators, who are longtime friends, Trinidad, Delia. I wish to thank particularly Ana, who has coordinated this for the group that supports the streaming in Uruguay. I will not say all the names, so thank you all. On behalf of Andrea, I congratulate you. This has been a year where we have shown enormous diligence, and we didn't lower our arms. We kept our seminars going, we kept working on papers, we kept accompanying countries, and we keep thinking that our mission is to take care of women. Our mission is to go on improving the health of women. So I thank you all for your participation today, and I wish you an excellent New Year. That this time there's also a time of reflection, that holidays are happening, whether it is Hanukkah, as it is my case, or Christmas, as it is for many others, that we may join 2021 with more hope and resilient, and hoping that we shall have a year with more health and more hope. Thank you very much to all of you, and we close the meeting here. Thank you.